Hello, Brooklyn. I am your host, Dr. Braha. Welcome to the Medcast Plus show. On this show, we feature local physicians and healthcare providers who will share their expertise with us to help us become a healthier community. Today, I have our guest, Dr. Stephan Balan. He is the Chief of Hematology-Oncology at Mount Sinai, Brooklyn, located in the Midwood area of Brooklyn. Dr. Stephan is an expert in his field and is here today to talk a bit more about the fields of hematology and oncology, the study of the blood and of cancers. We have a problem here in Brooklyn, a healthcare disparity problem. There is more cancer here, and access to care is sometimes harder for our population. Dr. Balan and I will talk today about hematology-oncology and the services that are available to our own residents here in Brooklyn without leaving the borough. Dr. Balan, thank you so much for coming on our show. It is just an honor to have you here.
Thank you for inviting me.
So Dr. Balan and I worked together over at Mount Sinai, Brooklyn, and I was just so honored when he accepted my invitation to come on this show, because cancer care and cancer prevention is key to the health of our community. And we're going to talk about that today. And we're also going to talk a little bit about Dr. Balan. So first, introduce to our viewers a little bit about yourself. Where do you come from? And tell us a bit about your education here in the States and what it is to become a hematologist and an oncologist.
Thank you. I was born in Bucharest. I'm originally from Romania. Actually, I came to the US in 1996, but just before I left, I started the fellowship in GI. And I came to New York, and in New York I went to do my internal medicine residency and then fellowship at NYU. I left New York in 2003 when I started working in New England at Dartmouth, where I spent 10 years in different settings. After I came back to New York for NYU, and then most recently, 2 years ago, I moved to Mount Sinai.
So here you are, back in New York. You spent some time in New England. It was too cold. You came back to New York, right?
Yes.
And it's important because you came back to an area of New York City that could really use your expertise. Cancer care, when I see patients, they often feel they have to go to Manhattan. They can't access care here in Brooklyn. But this is not true. Tell us a little bit about what Mount Sinai is doing here in Brooklyn to provide comprehensive cancer care to the residents of the borough.
So, as you know, Mount Sinai has now a hospital on Kings Highway, which is the old Kings Highway Hospital. And we have two oncology clinics, one in Sheepshead Bay and another one next to the hospital at 3131 Kings Highway. In this clinic, we have 7 chemo chairs and a full-fledged team, and we offer really the latest in terms of cancer care. We see hematology patients, we treat blood diseases, cancers, we give chemotherapy, we give immunotherapy, and hopefully we'll have some chance to talk a little bit about it. And we also offer blood transfusions. In the past, patients had to be admitted or to go to the emergency room and spend 8 hours waiting to be seen. Now they can just come to the clinic and have their blood transfusions there. We also give a vast array of therapeutics for Crohn's disease, for hematological cases, for all kinds.
You mentioned an important area of medicine, which is infusion. You mentioned chairs to infuse. And so for our viewers out there, explain to them a little bit what an infusion center is.
An infusion center is a place where patients come, they are roomed, they have their blood work done in the infusion center, they meet the physicians, they get their physical exam done, and then they, in case they need blood transfusion or therapeutics or chemotherapies, they go in a chemo bay, which is as comfortable as it gets.
I've seen this, and
yes.
it really is beautiful. The facility that Mount Sinai has built over on Kings Highway, the infusion center, the chairs are not really a chair. It's not what you would think of sitting in a doctor's office. They are recliners, they are comfortable, where patients can receive all sorts of infusions, whether it's iron infusion, blood, in a comfortable, clean setting, modern. From what I saw, it is state of the art.
It is indeed, and they have their own privacy. They have also space for a loved one to be with them. They have their own TV and spend their time in a nicer way than usual.
Right, because when I talk to patients sometimes, and we're talking about their diagnosis of cancer, there is still the thought out there that cancer care requires that someone be admitted to a hospital, that someone has to be in a hospital to get chemotherapy, that someone has to be in a hospital to get their treatments. But now, 2018, here in Brooklyn, New York, that's not the case. Cancer care has changed. Tell us a bit.
It has changed a lot. Patients in the past had to be admitted often to get their chemotherapies, and nobody wants to be in the hospital. Nobody wants to eat hospital food, no matter how good it is. Besides, you don't sleep well, everything is beeping all the time. There's also the risk of getting infections. It's a hospital after all. Now patients come to the clinic, they have their pre-medications to prevent allergic reactions and nausea and other reactions. And then they get their chemotherapy, and then they go home. It's a day like any other.
And they're getting state-of-the-art chemotherapy here in Brooklyn. The patients don't have to travel. I have so many patients who say to me, okay, thank you for finding my colon cancer. I'm going to now have to cross the river or go over a bridge in order to get the most modern cancer care. And that's just not true anymore. And they're surprised to find that you have a facility like this in Brooklyn, which is fabulous. So we talk a little bit here about what facilities are available to help treat patients who need infusions or cancer care here in Brooklyn, but let's back up a couple steps. Cancer prevention is more important. What can we do to prevent cancer? Now, there are certain cancers out there that we could screen for: colon cancer, breast cancer. Let's go over some guidelines or go over some recommendations. For our viewers today, it is important to understand that cancer should not be a diagnosis, but we should start as cancer being prevented. What are some tips that you have for patients who are healthy at home, worried about cancer? When should they start to get screened for some of the most common cancers, and what can we do for them?
There are several cancers that we can prevent. One of them is cervical cancer. We have now a vaccine that prevents practically cervical cancer. This has been an extraordinary change in the way we deal with.
This is the human papilloma virus vaccine,
Yes.
specifically for cervical cancer in females. The cervix is a part of the female reproductive organs. It's at the bottom of the uterus and the vaginal canal. And what Dr. Balan is referring to is a vaccine that is now available and recommended for women and children. Female,
Right.
starting in their teens, I believe, or
Yes.
young age.
Another cancer that you know more than I do in terms of prevention, it's colon cancer.
Right.
Nowadays you do the colonoscopies not just to detect cancer before it becomes symptomatic, but also to find polyps, things that can become cancer down the line. This is prevention.
Colon cancer these days is preventable. Patients come in and ask what are their options for screening, and we go over some of the options, and we talk about the dramatic drop we see in colon cancer in older people over the age of 50. The issue now is we are seeing a bit more colon cancer in the younger folks, somewhere in the 40s, and so the recommendations are shifting somewhat right now. Some of the organizations have come out and recommended that the colon get checked at 45 instead of 50. And very important for our viewers, the recommendation for African Americans is to start at 45. Other populations is still 50 years old, but the American Cancer Society has shifted and said, hey, listen, we should start checking at 45. So cervical cancer, colon cancer, these are preventable. What else should our viewers be looking out for?
The best advice I have is just to give up smoking, and that would probably prevent a lot of cancer.
Put a lot of doctors out of business if
Yes.
smoking didn't exist.
And some companies also.
Right.
When you look at the curves of incidence of cancer and the survival, they're all moving in the right direction. And one of the major factors has been to give up smoking. This being said, you have screening tests, and you mentioned a couple. Another one is for prostate cancer. Just very recently, the national guidelines have changed a little when it comes to prostate cancer. We used to screen everybody by doing a blood test and look at the PSA, and nowadays we're not very sure if everybody benefits from that.
But that really is on an individual basis.
Yes.
You know, for the men watching today, I always recommend to my patients, see the urologist, see your primary care doctor. Depending on what illnesses you might have or how healthy you are, they will find the right screening method and treatment method for you. But that's a big one. Men ask a lot about prostate cancer, and there has been some debate about how we should screen for that. You're right.
Right. And there needs to be an informed decision. It needs to be an in-depth discussion. And that's one of the nice things we do with a newly opened cancer center, is that we have the luxury of sitting down with patients and explaining them and involving them in making their own decisions. To be tested for prostate cancer is really an individual basis. Depends on your family history. Of course, if you're an African American, then you are at risk of developing prostate cancer early on and to have a more virulent type of cancer.
African Americans, like with colon cancer, we screen them a bit earlier because, yes, we do find things in the colon at a bit advanced stage compared to the average population. So the same with African Americans and prostate is what you're saying. And that's, you know, these are important factors. Is that for our viewers today, when you see guidelines, they apply to a large population, but when you sit down with a doctor like Dr. Balan or your primary care doctor, they can individualize the approach. So it's important not just to read online about a guideline, but to discuss it with the physician, get into the doctor's office and have an individualized discussion.
And this is very important because there's also a downside of overdiagnosing and over-treating. I worked at Dartmouth, among other people, with Lisa Schwartz, and I was very saddened to see an obituary in the New York Times yesterday. She was she died at a young age, at 55, of cancer, and she was a great advocate about empowering the patients and getting to know as a patient what's your risk to develop a cancer, to prevent it, to treat it, to die of it. But without an informed, it's not an industry. You're not on an assembly line. Everybody comes in, gets their PSAs. It needs to have a discussion.
Every patient is different.
Yes,
you know, the conversation with a physician is the most important part of healthcare because, you know, patients go online, they Google, they search on Yahoo, they search on the websites, and while it's good because we want our patients to be as informed as possible, there are studies in screening, there are studies in treating cancers that say for certain populations we should do A, B, C, and for another population X, Y, Z. And that's where your expertise is so important. So we talked a bit about prostate, colon, cervical, preventable and treatable cancers for the most part.
Cancer.
Lung cancer. Let's talk, you mentioned smoking. And here we are in Brooklyn. I know I get on the subway outside, people are smoking cigarettes. Outside the malls, they're standing there smoking cigarettes. Outside of a restaurant, smoking cigarettes. And it just kills me because this is preventable by just not picking up a pack of cigarettes. What can we do for smokers in terms of lung cancer if they already are smokers? What can we do aside from quitting smoking?
I'm really happy to see that now we have a good screening for lung cancer. For very many years, there have been studies starting from the 70s, and then 80s through 90s. There was no evidence that screening patients for lung cancer did anything in terms of survival. In other words, if you were a smoker and you had a chest X-ray and you check your sputum, there was no evidence that that would catch the cancer early or prolong your life. But now we do. And we have a very solid lung cancer screening program here in Brooklyn. To qualify, you need to be between ages 50 and 75 and to have a significant history of smoking. And it's a simple, low-dose CT scan, which can literally save your life.
We've had patients together, actually, at Mount Sinai, Brooklyn. We have a thoracic surgeon and a whole crew of pulmonologists. And we've had some patients, I've had some patients who went through a screening program where if they're in the age range you describe, they go for this quick CT scan. Very easy, very simple. The CAT scan is minutes in the room. And they can find these little nodules. And sometimes they have to be removed. And sometimes these nodules harbor cancer. And they're tiny. They're the size of an eraser on the head of a pencil. I mean, that's incredible.
This is incredible, and I think it saved a lot of lives. You mentioned the fact that nowadays people do not have to cross the river to go in Manhattan and get state-of-the-art care, and I really think that's true. And we made this possible at Mount Sinai because we have some good oncologists who know what they're doing, but also because we are in constant communication with what we call the disease groups. Bladder cancer, prostate cancer, breast cancer, lung cancer, colon cancer, where we present the patients at tumor board, where you have the world specialists, looking at the data, coming together with a plan, and then instituting it locally.
That's a great point that you bring up. And for our viewers today, there is something called tumor board. And when I was first in medical school and they said, hey, can you present this case for tumor board? I was scared. I thought I had to go walk in front of a board of people. I didn't know what tumor board was. It was one of my first rotations. I was actually at Maimonides Medical Center, where they had a cancer center that I was working at as a student. And they said, well, why don't you present your patient to tumor board? It sounded like this terrible, scary meeting where you walk in and there were judges sitting at a table. But in fact, what Dr. Balan is referring to for our viewers today, to explain this to you, is in a room, on any given day at any hospital in the city, any comprehensive hospital, there is a tumor board going on, and there might be a tumor board for lung cancer or a tumor board for colon cancer, where they present the patient. And we spoke a little bit a few minutes ago about individualized care. And the doctor will present Mrs. Smith or Mr. Jones and talk about their case, talk about, is he a marathon runner, or is he someone who's stuck in bed? Is this someone who's in good health or bad health? What did we find? And the doctors, and there could be dozens in the room, will put out all what they think is the best plan for this patient. So that while there are guidelines and there are algorithms out there, the care still becomes individualized, and they try to find the best choice, an evidence-based choice. And here in Brooklyn, you do that.
Yes.
For all the different types of cancers, and the patients are presented to experts. And so, when the patient meets with a cancer doctor, and I was surprised to learn this. When I first worked at Sloan Kettering, I had seen how this goes on as well, where one doctor comes in the room, and then another doctor comes in the room. And here in Brooklyn, you're putting this team together so folks don't have to cross the river. So once a patient is presented for tumor board, say they went for a screening test, and we find a colon cancer. What's the next steps locally? What can we do here locally? We find a colon cancer that needs to be removed. Say they have to go for some chemotherapy after. How can we facilitate this without crossing a river?
Sure. Just to add to the idea of tumor board, it's the only place where you can have a 360-degree view of everything. Because at the tumor board, you don't have just oncologists there, but you have people who read films, the radiologists, you have the radiation specialists who give the radiation, you have the surgeons, you have the pathologists who read the slides and make the
all
diagnosis.
The doctors just come
Everybody.
together for the patient, for the sake of the patient. It's really a beautiful thing.
It's an extraordinary, it saves time. Just imagine that the patient would have to ping pong between different specialists. And it also puts everybody on the same page, because you have your own angle and somebody else has another angle. The gastroenterologist will have another angle. And that's the only way to get a comprehensive view.
Right, so the patient who comes in with a new diagnosis of colon cancer, here locally, you can put the team together where the surgery can be discussed and arranged at the tumor board. The type of chemo that may need to be done after can be arranged, or the radiation therapy can be arranged locally, comprehensively, where the patient is now presented with a packet or a plan. And they never even saw this meeting take place.
Right.
It's sad, because I wish patients had seen this, because it would give even more appreciation for what goes on behind the scenes. It's not just the office visit. It really is incredible.
Right. You mentioned the colorectal cancer patient. When somebody is diagnosed with colon cancer, that's done by you, by the gastroenterologist, then we have this tumor board. You have the surgeon, pathologist, the radiologist, the medical oncologist, and then within just days, you have the medical oncologist see the patient. You have the radiation in case the patient needs radiation. The chemotherapy can start as soon as the surgery is done. We're building in Brooklyn here a GI Center of Excellence where your group works with Mount Sinai and with the surgeons and the medical oncologists to make a team and to have the patients be seen by everybody in record time.
What Dr. Balan is referring to is what we call in medicine comprehensive care or integrated care, where as a gastroenterologist, I can do a colonoscopy. I find what I know to be a colon cancer in the patient in my office at 9 a.m. on a Monday. At 9:15, I have a text message out to, say, Dr. Balan or one of the cancer specialists here in Brooklyn. I have a text message out to one of the colorectal surgeons where they now have robotic colorectal surgery at Mount Sinai, Brooklyn on Kings Highway. So the patient now, I've got text messages out to all the experts locally. And so what he's referring to is comprehensive cancer care in the same zip code that the patient lives, which is fabulous. 2018, this is what we should be offering not only here in Brooklyn, but everywhere in this country, because we are so advanced now in medicine that why not have locally the right care? And so we've done this together for some patients.
Absolutely.
Even recently, and it's fabulous because all the doctors communicate easily. We know each other. We're local. We're Brooklyn people.
Yep.
And Brooklyn has needed this for a long time. So let's move on here. We talked a little bit about prevention of cancer. Patients, we talked about chemotherapy. It's changing. It is not what we thought of in the 80s, 70s, 60s, where every cancer requires brutal chemotherapy, where the hair falls out, people turn pale, they look sickly. There are some new changes, there are some new developments. Tell us about some of the latest and greatest in cancer care.
Excited to do so. I mentioned this to my students 75 years ago on December 2nd, and it is 75 years ago, it was 1943. In Bari, during the Second World War, there was a bombardment of a ship that had a secret load of nitrogen mustard. And the dead underwent autopsies, and they noticed, and Goodman and Gilman, who wrote the textbook of pharmacology, were on this, noticed that the lymphocytes disappeared in these patients. And it's the first time they asked themselves, maybe we should use nitrogen mustard, to treat patients rather than to bomb places.
And the lymphocytes, for our viewers, are a part of the immune system. They are a white blood cell. And so these folks were exposed to this chemical, and they found that part of the lymphocytes disappeared, which led them now to
the development of chemotherapy to fight leukemias.
By accident. They found this by accident,
more or less by
basically.
accident, yes. But the fact that the birth of chemotherapy is linked to such a humanitarian disaster, it tells you that chemotherapy does not have a good name, and for the right reason,
Because it's tough.
It's non-specific.
Right.
It attacks the DNA. That's the fundamental principle behind any kind of chemotherapy. And then you end up with all kinds of adverse reactions.
Because the chemo doesn't know, or at least the chemos that we have been using in the past, they don't know exactly where they're going. They're affecting the cancer, but they're also affecting the body.
Right.
But now you have targeted therapies.
Targeted therapies were studied in the 90s. I think 2001, the first one was the Gleevec, was imatinib, was discovered. Targeted therapies means that you create a medication that looks for a very specific target only on the cancer cell. I sometimes joke that there was a movie, there was a Top Secret, when there's a brawl in a bar between the partisans, the French partisans and the Nazis, and somebody comes and starts shooting left and right with bullets, and only the Nazis fall. That's the concept behind targeted therapy. So give the medication, but the medication will selectively kill only the cell with a very specific target on it. And we're very excited in the early 2000s when these came out, erlotinib, imatinib, all these IBs. And we had good results. They're much better tolerated. They're not as targeted as we wish they were, but infinitely more so than the chemotherapy.
And we're getting there also now with immunotherapy.
Yes.
And some of these are not chemotherapeutic agents. These medicines don't always have to be IV. They don't have to be shots. Some of them are pills now, in fact, correct?
Yes.
So patients don't have to fear that a diagnosis of cancer means an IV infusion or terrible chemotherapies like they've seen in movies. Some of them, and many of them now, are targeted, and we're getting even more directly aimed at the specific site, sometimes by just a pill.
Yes.
We have a minute or so to wrap up here. We talked about prevention. It is important, so important for our viewers, to see a doctor, to get a colonoscopy, to get cervical cancer screening, mammography. If you're a smoker, stop smoking. If you're a certain type of smoker in a certain age, get a CAT scan that's been designed to detect lung cancer early. Then, God forbid you find something, cancer care is available locally. There are infusion centers. People don't have to be in hospitals. So I want to thank you for coming here today to explain this, because Brooklyn, unfortunately, has been underserved for some time. There is more cancer in Brooklyn, but the folks watching today need to know that the cancer care is available locally and that they can prevent cancer, in fact, by seeing a doctor like you, seeing their primary care, and really pursuing a healthy lifestyle. And we talk about it all the time, stopping smoking. So thank you for coming on today.
Thank you so much.
It's really an honor to have you on, and what you're doing here locally with Mount Sinai Brooklyn on Kings Highway to bring such comprehensive expert care to the residents of Brooklyn is amazing, and we're happy to have you.
Thank you. It's a privilege, and I'm humbled.
To our guests today, thank you for your interest in the show and for watching Medcast Plus. We invite you to continue to watch to become more involved and educated on your health. I invite you to visit our website at medcastplus.com and check out our tools and connect with us on social media. You can also call us at 718-510-2103. I'm Dr. Jack Braha. Stay healthy, be well, stay safe, Brooklyn. Goodbye.